So before going to the topic, I'll just give you a brief description about the tunnel, their rehabilitation trust. So tunnel works in 17 states and 2 union territories across India. The major areas of function services are divided into health, welfare and development, and education. And under health, community psychiatry is one of the main activity. And you can see we also have early intervention centers, special schools, vocational rehabilitation for differently abled and destitute persons. So under community psychiatry, per se, we have directly under community psychiatry, we have 54 community clinics where we offer services with the help of the community stakeholders based on assertive community treatment model. And we also function in 20 early intervention centers across Kerala, where 2 centers are super specialty early intervention center, which has robotic assisted therapy as well. We have 7 special schools, 15 vocational rehabilitation centers, 3 psychiatric hospitals, daycare centers, and 11 care homes. So coming to the Tunnel Community Psychiatry Online Academic Series, this is the third session. We started in February with the topic of managing diabetes for psychiatrists. Second session was neuropsychiatric complications of alcohol disorder by Dr. Jayakrishnan Menon, and this is the third session, addressing core deficits of autism spectrum disorder by Dr. Dharani Ramamoorthi. So Dr. Dharani did her MBBS from Chennai Madras Medical College, MD from Central Institute of Psychiatry. She completed 3-year senior residency in Central Institute of Psychiatry, especially mainly in the child and adolescent unit. Now she is pursuing her DM, child and adolescent psychiatry from NIMHANS. Over to you, Dr. Dharani. You can share your screen and start the presentation. Thank you.
Thank you, Dr. Lukman. Hello, everyone. I'm Dr. Dharani. My presentation will be on addressing core deficits of autism spectrum disorder today. Today, I'll be presenting largely with an introduction to autism spectrum disorder and how to diagnose autism spectrum disorder, and what are the assessments we are going to do when a child is diagnosed with ASD, and how to identify targets for intervention and how to go about intervention. So, when we talk about autism spectrum disorder, we all know it is a developmental disorder. As we see here in this picture, a normal child will have development which is occurring at age appropriate stages, whereas with global developmental delay, there can be delay in all developmental milestones, which is equally seen in all domains. Whereas when a child comes with autism spectrum disorder, the delay is predominantly seen in communication and social milestones. And yeah, even that communication and social milestone delay can be uneven. There can be initial development followed by some regression, and then the child may catch up on those delay in milestones again as well. So it is crucial for us to understand whether the child has global developmental delay or it is just autism spectrum disorder with delay in social and language milestones. So, what are the red flags that we are going to look for? We are going to look for lack of big smiles or joyful expressions by 6 months or thereafter, or there are lack of back and forth sharing of sounds, smiles by 9 months, lack of babbling by 12 months, and no back and forth gestures such as pointing, showing, reaching, or waving by 12 months, no words by 16 months, and by 24 months, the child may not be speaking at least 2 word phrases that should be meaningful, and any loss of speech, any babbling loss, or any social skill loss at any age. When we are seeing these red flags, then we should be assessing for autism spectrum disorder. So generally, children will go to pediatrician regularly and bell baby clinics where these red flag signs should be monitored, and they should opt for early intervention. So why red flags are very important? Because a lot of time we see children where parents and the family members believe that he will develop with age, there is nothing to worry about it. Now the child is not speaking, after 6 months the child will speak. Generally they have this notion over a period of time the child will develop. So it is essential that we should look for red flag signs and start early interventions. Why early intervention is necessary? The child is still developing, and the learning will be very faster when you start interventions early, and the outcomes are also better. And the intervention can be started as early as 12 months as well. So, but we commonly see children coming to us at around 3 or 4 years of age, and they generally present with these complaints where they say that the child has poor eye contact, does not respond to name call, not talking at age appropriate level, and there are some repeated behaviors, and the child does not follow any instructions. The child is in his own world, and the child has learned those language skills earlier. Now the child is not able to speak, and they say rhymes, they have words, but they are not using it to communicate functionally, and they do not prefer pure play. They play solitary, they have solitary play, and they do not play uh, turn taking games. So these are the complaints we generally see children presenting with at around 3 or 4 years of age. So how do we go about diagnosis? We all know the diagnostic criteria for autism spectrum disorder. That is persistent deficit in social communication and social interaction that should be across multiple contexts: home, school, and community settings. And the deficits should be noticed in social emotional reciprocity, non-verbal communicative behaviors, and verbal communicative behaviors, and difficulty in maintaining or understanding relationships as well. And we also see restricted and repetitive patterns of behavior, where there can be higher order repetitive restricted pattern of behaviors like insistence of sameness, inflexible adherence to routines, or it could be lower order, or are these like stereotyped repetitive motor movements or use of objects or speech. And there can be sensory seeking or sensory registration difficulties or sensory sensitivity as well. So all these should be noted in the early development period, and it should be significantly impairing the functioning. So we all know the diagnostic criteria for autism spectrum disorder, but the diagnosis becomes difficult when the child presents with lot of the comorbidities. So as we can see over here, autism spectrum disorder will include socio communication difficulties and RRBs, and in addition to that, now language impairment can be there, or there need not be any language impairment for diagnosis of autism spectrum disorder as well. And the child may also present with intellectual disability. 30% of children with autism spectrum disorder do have intellectual disability, and comorbid ADHD is also quite high. So they also can present with other psychiatric diagnosis, which is a comorbidity like a OCD or any mood disorder, anxiety. Any other psychiatric disorder can also be a comorbidity. So the diagnosis becomes difficult when when the child presents with these comorbidities. At this point, detailed history taking and doing assessments help us understand and delineate the symptoms that the child may be presenting with. In addition to that, 20 to 25 percentage of children with ASD will present with developmental regression. In such a situation, we have to evaluate and rule out for neurometabolic disorders and epileptic encephalopathies. And generally, it is seen that they may get precipitated following any fever or seizure or any gastrointestinal symptoms. And the regression can be only in language, or can be only in social and language domains, or it can be global regression also. So whenever a child presents with incontinence and motor regression, we should look at the possibility of childhood disintegrative disorder as well. All these things will help us understand the comorbidities, and will also the prognosis will also be different. So there are some genetic syndromes also. Whenever a child presents with dysmorphic faces, then we might have to think of genetic syndromes like Fragile X syndrome, neurofibromatosis, tuberous sclerosis, Angelman syndrome, and Rett syndrome as well. So once a child presents to you with the developmental delay, then we'll have to proceed for detailed history taking, whether there are any core deficits that are seen in autism spectrum disorder are seen in this child, like socio communication deficits or RRBs. Then we'll have to go for a detailed developmental history where we are looking at each and every domain. What are the milestones that the child has achieved, and whether there is any delay or regression. And especially nowadays, there should be we should also evaluate for exposure to electronic media as well, because we see a lot of children who present with autism spectrum disorder, and there is lot of understimulation happening, and the child may be more exposed to social media, electronic media, and socialization with adults and peers are not happening. So whether they have any opportunities to interact with peers or adults, that should also be clarified. Then we'll have to look for family history, any attachment difficulties, stressors, coping mechanisms, who are the primary caretakers, what are the parenting practices that are seen in the family as well. So sometimes even children who have anxiety may also be diagnosed with autism spectrum disorder, where the child may be selectively mute with people outside the family, or they may not speak much because of anxiety. So we should be careful regarding attachment patterns, stressors, whether anything of that sort is present. And we should also take treatment history. So since some children may present with some treatment where they have tried some ABA, they have tried some speech therapy, occupational therapy, but they were not seeing any response to this intervention. We'll have to understand what are the interventions that are given and what are the targets that they have planned, whether that was whether the child had any difficulties during those interventions. That will help us plan our interventions. And comorbid medical illness, schooling history, and should also be gathered, since lot of children with ASD, they stop going sending the child to school because the child is not learning anything and the child should be sent only for the therapy. But one where school provides an opportunity for the child to socialize with same age peers. So schooling history and what are their parents understanding regarding schooling should also be clarified. And the most important thing is that what is the current functioning of the child, what is the current routine for the child, what are the current skills that the child have. These needs to be assessed in detail, which will help us in planning our targets. And the child talents and the likes of the child should also be elicited, that can be helpful in you for reinforcing the child during these interventions. So once we are sure that the diagnosis of ASD is made, we generally go for assessments. The first set of assessments will be helpful in screening and diagnosis. CAR, chat, all these can be used for screening, whereas autism diagnostic uh, schedule or even ESA can be used for Indian Scale for Assessment of Autism can be used for diagnosis of autism. And once we also go for intellectual functioning assessment, we generally prefer doing non-speed tests, since the children may not be able to perform well with speed tests because of ASD. And when the child has high IQ and the school may require detailed IQ assessment, then we can go for this 4 or MISIC as well. And when we have to plan for UDID facilitation, then INCLIN and Indian Scale for Assessment of Autism are the preferred tools for disability assessment. So in addition, we may also go for MRI and EEG if there is a history of seizure or regression or any suspicion of seizures, and new metabolic testing for inborn errors of metabolism if there is a suspicion of neurometabolic disorders or any regression, and genetic testing in the presence of any dysmorphic faces or comorbid intellectual disability or family history of autism is there. And we have to rule out visual and hearing impairment as well. So once we have made the diagnosis and we have made these investigations and assessments, we generally have a multidisciplinary team with which helps in assessment as well as intervention, like clinical psychologist for the assessment and inputs, and psychiatric social worker to address family stress and disability certification and social interventions like placing the child in school, and speech pathologist and audiologist for speech language assessments and therapy, and physiotherapy and occupational therapy referral, and neurology consultation if there are any suspected seizures or developmental regression or any suspicion of metabolic disorders are there. So now we are coming to the main aspect of today's webinar, which is interventions for core deficits of children with autism spectrum disorder. So we largely go for naturalistic developmental behavioral interventions. So what do we mean by naturalistic developmental behavioral interventions? So whatever interventions we are providing, it should have a developmental framework. Like the focus area should be based on the current developmental level of the child, whatever skills that the current child currently has, and what is the next level of skill that the child can achieve. So the intervention should focus on the child's developmental age. Then behavioral framework. When we talk about behavioral framework, we talk about using applied behavior analysis principles, where we use prompting, modeling, shaping, and chaining, and also use of reinforcements for desired behaviors. And it should happen in naturalistic settings. It should happen at home, it should happen at school, and it should happen at community environments. And all these skills that the child is learning should be integrated in the daily routine of the child, so that the child's skills get generalized. Earlier, there were ABA framework, where the child is made to sit in a chair in front of you, and the cards will be shown. The child may see that this is a car, and if the child identifies that this is a car, then a reward will be provided, like maybe a toy that the child likes, or any biscuit, or any snacks like that. So here the reward may be artificial. So here we focus on having the child playing in a naturalistic environment, where the child is playing with a car, and during that time we are identifying that this is a car, and the car playing with car is given as a natural reinforcer for the child. So, in naturalistic developmental behavioral interventions, children are seen as active participants. They should initiate the play. Initiate Once the child initiate, the adult joins in the play and helps the child learn. And we take constructivistic approach in NDBI, where the child will actively seek to learn and build on earlier knowledge that the child has, and new experiences will help the child add on to the existing knowledge that the child already has. And also it should be developmentally appropriate, as I have said earlier. And we look for zone of proximal development, whatever the skill the child currently has, and what is the next zone of proximal development that the child can achieve. And also the learning should also be an integration of social language, cognitive skills, and knowledge. It is not one domain, it is cross domain learning, where a child is playing a puzzle. Then it doesn't it need not only involve cognitive skills. Playing, turn taking during that time will involve social development, whereas talking about the puzzles will involve language development. So the learning is generally cross domain learning, and it should happen in natural context. And the skill development should happen in an affectively rich social interaction, where the parents or the caregivers talk in an emotional manner, where the emotional expressions of the adults are exaggerated, so the child pay attention to the emotions. And it should be affectively rich social interaction, and it should be meaningful to the child, it should be enjoyable to the child. And in those contexts, learning generally happens. And what are the principles of training that we have? The training should occur every day, and it should be integrated into the daily routine, and all family members need to be involved. And the training program and targets will be based on individual child's profile, and the training should be pleasurable for the child as well as the family. And uh, the child should be immediately and consistently reinforced upon completion of the task. And the reinforcers need to be varied to maintain the child's interest. And once the child's interest is lost in the task, we may move on to the next task. And the task should be planned based on the child's strengths and likes. And play is used as a medium of training, where children are allowed to engage in free play. Let the child choose the activity, and the parents or any caregivers can sit face to face with the child during play. And they can observe how the child is playing, and then the adult can approach and join the play. And whatever the child is playing, that can be imitated by the adult, that can be described by the adult. And without asking any questions or redirecting the play, adult can join in and imitate the child's actions. And whenever the child is showing any interest, or looking at the caregiver and giving an eye contact, even as subtle as just fleeting eye contact, that should be reinforced with appropriate animated and different facial and verbal expressions. And while play, we generally keep a few toys rather than keeping all the toys together to keep the distraction minimum. And also the toys can be kept out of reach but in the view of the child, so that the child can request for the toy that can be helpful for initiating communication from the child's end. And when the child initiates the communication, the request can be modeled by the adult by saying, what does Ryan want? Ryan wants a car. Then that can be, even the child makes an eye contact, the adult can say, what does Ryan want? Ryan wants a car, and the car can be provided as a reinforcement. And once and also during play we introduce small changes. And also once the interest wanes also, we can change on to another play. And different games can be used to teach different skills, like using pretend play can be like using can be used to help the child understand feeding, bathing, all these routines. Once the child is able to play games with one adult, generally other people can be involved to help the child move on to peer play as well, group play as well. Then we come to identifying targets for interventions. So generally we use early start Denver model checklist and communication deal developmental checklist, com deal, and Catherine Morris checklist as well. So basically, SDM checklist has these domains where receptive communication, expressive communication, social skills, play skills. We have these domains, and the skills are divided into level 1, 2, 3, and 4 based on the age, like 12 to 18 months, whatever the child is supposed to achieve will be in level 1. So it is up to 48 months. Whatever the child is required to achieve, that is provided in ESDM checklist. As we can see, level 1 in receptive communication is like localizing to sounds by turning towards sound source, looking to playful vocal sounds, responding to voice by turning towards person. So whereas in expressive communication uses a goal directed reach to request, vocalizing with intent. So these are level 1 for different domains in ESDM checklist. Similarly, we have COMDEAL checklist as well, which has gross motor, fine motor, activities of daily living, receptive and expressive language, cognitive domains, socialization, and emotional domains as well. Similarly, uh, Similarly, we have categories checklist, which has a beginning, intermediate, and advanced curriculum guide, which has attending skills, imitation skills, receptive and expressive language skills, pre-academic and self-help skills domains. Once we diagnose a child with ASD, we have ruled out all the neurometabolic disorders, and we have to plan the interventions. We apply these checklists to identify these targets. So in these checklists, I assess for current level of functioning and skills in each domain, and the child's most mature skills and currently emerging skills, and the skills that are currently not in the child's repertoire are marked. Like we can see in this domain, we have shaded domains that items that the child is able to do, and the domains that the child is able to do but not consistently are shaded in different way. Whereas the child, if the child is not able to do that, then it is left blank. So it gives us a visual understanding. Similarly with ESDM checklist, with Catherine Morris checklist also, we try to see what are the skills that the child is able to do consistently across different domains, and consistently across different situations with different people, and whether the child is able to perform consistently. If that will be marked, the next stage will be inconsistent performance. The child may be able to do those skills with parents, might not be able to do it outside the therapy settings. So those inconsistent performance is also marked. Then we plan the targets. So the targets will be the whatever pass fail items, that are the items that the child is performing inconsistently, and the next few items that the child is not able to do. And we formulate the objectives that the child should learn for the next 12 weeks using this curriculum, where we take 2 to 3 objectives in each domain. and then we select the antecedent for this behavior. So we take natural cues for this behavior, and then we plan how it can be implemented in the therapy setting. And we also specify the behavior that the child should be able to do during the therapy setting, so that it is observable and measurable, and we will know whether the child is able to learn these skills, and whether, and the quantity and the accuracy with which the child should be able to perform these skills, everything should be specified. And also generalization criteria, where the child should be able to perform, with whom the child should be able to perform the skill, that is also to be specified while we are planning targets for the child. Let me give an example. For example, the joint attention is the primary target here that we'll be working on. So writing the objective will involve in what situation the child should be able to do, how frequently the child should be able to do, and what will be the observable behavior that will help us understand whether the child has learned this behavior or not. For example, in this objective, they have written like, during social games with objects like bubble maker or noise maker, the child will make joint attention to share affect involving eye contact with partner, that will be done by alternating gaze or smiling 3 or more times in a 10-minute period. That should happen across 3 consecutive periods for two or more partners and objects. So how this can happen? Initially the child may make occasional eye contact, so then the child make repeated eye contact, but consistently the child will make eye contact. Later on the child may start smiling along with eye contact, then the child may be consistently able to smile and provide eye contact to continue the interaction. Later on, the child may be alternate the gaze between the adult and the object that they are playing with. That can happen 3 or more times during activity. And later on, this the same thing can happen with 3 or more people, or 2 or more partners with 2 or more objects, and 3 or more times during the entire activity period. So while we have this target, joint attention is the target. This is how we are going to make the child learn this objective during this therapy session, and this is how we are going to these will be the steps through which the child will be able to learn this skill. Similarly, if we want a child to learn 5 consonants that the child should use intentionally, then initially the first step will be, whatever first step that we are taking is the step that the child is able to do already. The child may be able to use 1 or 2 consonants that is self-directed, which is meaningless out of context. Then the next step will be to help the child use those 1 to 2 consonants in a responsive, meaningful manner. Then maybe use it in a 10-minute period that we are there with the child. Then maybe 3 to 4 more consonants, and 3 to 4 more consonants in 10-minute period, and finally using of 5 consonants responsibly in a 10-minute period. So we plan the targets, and we plan the learning steps, and how we are going to teach the child during the session that we are supposed to do with the child. So how we are going to plan this activity? It should be of child's interest, whatever strengths and the likes the child has. We should have similar objects in play during our therapy session, and the child's interest will begin the activity. Then the adult can follow the child's lead into the activity, showing exaggerated facial emotions and talking in a rhyming like manner. And then we can make it interesting and reciprocal by taking turns and imitating child's actions, and adding interesting effects to play that we are playing with the child. Then we can co-construct the activity, where the child will add on to the activity and the adult can add on to the activity. During this play, we are teaching the child target vocabulary, stimulating the child to imitate, or maybe developing symbolic aspects of play. And the activity continues to be dyadic and reciprocal as well. Once the child loses the interest, then the child may move on to next activity, and the adult can again follow the child's lead into the next activity. How do we do that? Let's see an example. So a child and a father are playing on the floor. the child reaches for the balls on the floor. So then they start playing by throwing and catching balls alternatively. So once the father throws the ball and the child drops it, the child can cues the father cues the child by asking where is the ball. So the child runs and picks the ball and throws it towards the father. So the father throws the before the child throws the ball towards the father says 1, 2, 3 and throw. When the father catches the ball, they both explain catch, and they exchange looks, smiles and laughter. And similarly, then they can continue to play by saying the same things for few more times, saying 1, 2, 3 and throw. So it should be in an exaggerated manner, smiling and laughing, so that the child, yeah, they are exchanging positive affect between each other. And later on, the father can include further vocabulary, teaching further vocabulary in this play by saying big ball, and teaching the word catch, teaching the word throw. So they can alternate by they can make the game further interesting by alternating between big ball and small ball, and saying big ball and small ball. So they can continue to play for some time. Once the child appears to lose interest and turn towards other objects, then the father can move on to the other activity that the child is interested in. Like here, the child moves on to a book, and they start talking about the book and commenting on the picture, that it is a bird. So here, after that, the father can make the action of fluttering of wings with his hands with a sound effect, so that the child is so that activity is interesting for the child, playful and also enjoyable for both the child and the father. So so whenever we are planning an activity, we write an objective where this is the target objective, and this is how we are going to teach, and these are the steps that we are going to do during therapy session. And once the child is able to do that, we also monitor that and track the progress by saying that the now child is able to do 1 to 2 consonants. Next, the step that the child is about to acquire is there, that should be marked as inconsistent, and so that we'll be able to understand whether the progress is happening as we expected. And this should happen during the play, where the activity should be enjoyable for both the child and the adult who is with playing with the child. And sometimes it can happen that the child may not pay attention to whatever we are trying to do. So since children with autism are generally attuned to physical environment, we should take the child to a room with only age appropriate toys, minimum number of toys, and whatever that could grab the child's attention should be removed, that competition should be eliminated. And we should be at the center stage, where we position the child face to face. And then when the child start playing with any objects or playing with us, then we have to comment and be helpful with the child by imitating the child, and we can add variations, like the father did variations by talking about big ball and small ball and elaborating the play. And then taking turns and controlling the play material, the child can do. We can provide variations for the play, and once the child's interest being so, we can move on to the next play. So here again, this talks about how there should be a setup, and there should be a theme, and there should be some variation in the theme. And once the interest being off, they can close this play activity and move on to the next play activity. Here the child might not be that interested in doing a pegboard activity with the mother. So the mother is trying to understand, when should I get the attention of the child. The child will be having snacks in his chair. During that during that time, the child will be sitting for a while, and we can get the child's attention. So the mother finds the right time and tries and sets up the pegboard on the table while the child is having the snack. So this is the setup where we are trying to teach the child and play with the child using the pegboard. So there should be a setup phase where we plan the activity. Then the theme is where we start putting the pegs and helping the child put the pegs in the tray, and also taking turns between each other and talking about it. So that is the theme that we will try and do. Then we can hear the mother sets up the tray and puts in some pegs, and then she asks for the child to put in the pegs as well. Oh, I have done one, two, this is your turn, you take up, you do it. So they can take turns and start doing it. And when the child feels that the mother thinks that the child may lose the attention, they can vary the game by spinning the tray and with the pegboard, so that the attention is sustained for little longer time. And then the child, once the child attention is completely lost, then they can move on to other activity. So, how do we do these things? We have two types of joint activities mostly, where sensory social routines and also something called object based joint activities. In sensory social routines, it is there are no objects that we are using the play. It is the focus should be on the partner's attention, and the focus is on mutual pleasure and engagement rather than playing with objects. It's like games like peekaboo, games like wheels on the bus, so where there are some motion, some gesture that we are going to do, and we'll focus on the facial expressions, voice and body movements to help the child pay attention to the other partner, and also to learn gestural communication and verbal communication as well. Whereas joint activity routines where we can use objects like the pegboard activity that we have seen, it happens where there is a theme where the teaching is happening during the theme, and there can be imitation as to how the pegs can be put in the board, and taking turns, and how the materials are managed, and how we are varying the theme, and letting the child know how to communicate, how to learn vocabulary. This happens in object based joint activities. So typically in a 1 hour session, there can be greeting song and followed by some object activity, some sensory social activity like ring around the rosy rhymes, and there can be a movement activity and object activity and another sensory social routine, and again another movement activity, and maybe showing the books and teaching the child by showing the books, and maybe another object activity, and finally goodbye greeting. So each activity does not focus on single domain, it focuses on multiple domains, where an object activity like a puzzle based object activity can focus on fine motor skills, cognitive skills, play skills and communication skills. Similarly, motor movement activity like throwing balls at bobo doll, so it can be like imitation, gross motor, it will involve gross motor skills as well, and communication. So we plan joint activities during the session, which will be a sensory social activity or an object based activity, which will provide us opportunity to treat the target skills for the child, and the target skills can be across different domains as well. So, how do we teach these skills? Once we get the attention of the child, we will start by teaching the imitation skills, because joint attention and imitation are the prerequisites that the child should have for learning language. So, how do we do that? Initially, we can start by imitating the child's actions. Once the child notices it, we can reinforce the same by smiling, or we can sit in front of the mirror with the child and copy the child's action, and we can also reinforce when the child copies our caregiver's action. Initially, we can start with imitation of gross motor actions, then fine motor actions, then gestural imitation, and orofacial imitation. When we talk about object imitation, we start with gross motor activities and fine motor activities, whereas with gestural imitation, like in sensory social routines, where the child and the caregiver are singing a song, which is singing a rhyme, where they can make gestures like head nodding, pointing, handshaking, which can be gestural imitation that can be taught. And then comes the orofacial imitation, where we teach the child by doing activities involving body parts like blowing bubbles, which helps in initially understanding and learning the sounds. then we start, once the child is able to learn motor imitation, then imitating vocal sounds and gestures, then we go for development of non-verbal communication, where we can teach both natural gestures and conventional gestures. Natural gestures is like, we provide opportunities for the child to communicate. So instead of fulfilling all the wants that the child will have, we wait for the child to come and ask us, and that the child will initiate to ask for their needs, and that gesture can be shaped into clearer gestures. Like if the child is coming and looking at you asking for a water, then we can say, do you want water? Yes, you want water, and the water can be provided. This can be used as a, so that the communication can be used as this can be used as an opportunity to teach communication with the child. Whereas with conventional gesture, the child may request for an object. So where you understand that the child wants an object, you can show some two highly preferred objects, so that the child may point at one object or the other. If the child is not able to do, we can physically prompt, so that the child will be able to learn prompt pointing through these opportunities. So then comes development of verbal communication. Once the child is able to use non-verbal communication and gestures, then we can develop verbal communication by speaking more around the child during play, and using daily routines where we are using simple sentences and an animated voice and exaggerated facial expressions to promote the speech. So initially the child may not be able to express as much as we are expressing. This continuous speech stimulation will help the child's understanding of language significantly. So initially, through imitation, we will develop the repertoire of sounds like blowing bubbles, like saying bub bub ball. So initially, the child will be able to learn the sounds. Then from sounds that can be, then we can move on to words by matching the child sounds with related words, and then from words to multiple words, and from multiple words to sentences that can be gradually built on based on the existing knowledge of the child. So, in addition to this, we should create opportunities for communication. While engaging in play, we should pause for some time to make the child anticipate and request the parent to continue the play. We can pause in between the child's favorite song, so that the child can look expectantly at the caregiver. While blowing bubbles, maybe we can stop in between. Once the child looks at our face, then we can start blowing the bubble again. So these sort of opportunities we can create for communication, and that should be reinforced as well. And whatever we are doing with the child, we should use simple short instructions, familiar phrases, and saying the child's name at the start of the instruction to get his attention. And this will help the child to develop a situational understanding rather than vague suggestions. It should be clear, direct, and specific instruction, which is short and easier for the child to understand. And the communication should be whenever the child, sometimes children may use words which are not meaningful. So whenever they are saying some, having some echolalia or meaningless use of meaningless words, that should be made contextually appropriate by modeling and also prompting by the adult. And we can, once the child is able to use multiple words and be able to use sentences to communicate, we can use stories to help increase the understanding of the child. This will help improve comprehension, sequencing, analytical thinking, and understanding of the perspective of others as well. And when we come to socialization skills, we can teach the child joint attention, pointing, and peer play by modeling, followed by prompting the child to do that. Where when the child is playing in the playground, and we can model by saying, let's go play with this child, hi, let's go say hi. So these sort of things where the adult can model by saying that, to help the child communicate and initiate the socialization with the peer. And then when the child is going, the adult can prompt to initiate the communication with the other peer. And largely children who present with the behavioral difficulties, they generally have difficulties in communicating their emotions. So developing emotional vocabulary is very important in children with autism, where we can, when the child is smiling and laughing, oh, you are happy, you are laughing. So using those words so that the child will be able to appropriately label their emotions and also others' emotions. When someone else is smiling and laughing, that should also be labeled so that the child is able to understand and label their own emotions and others' emotions as well. And the child should also be taught of personal and social spaces, using pictures, using photographs. Whenever child is presenting with some behavioral concerns, these could be the reason where the understanding of personal and social spaces the child may be lacking. And the social stories will also help a child understand how to behave in a social situation, where it is a short story which will have a situation and who will be there and what will be happening and where this will be happening, when it will be happening and why it will be happening. And it will be including the perspective of others and how they should respond appropriately in that situation. And it can be used for daily routines as well, what they are supposed to do during a bathing routine or a brushing routine. And this will help them teach the desirable behavior. For example, every day I go to recess, this is the situation. I go to recess after lunch, this is when it is supposed to happen. And first I put on my jacket, then I line up, what am I doing in this situation. If the weather is nice, I go to the playground, I can choose to go on the swing, slide or jungle gym. Sometimes I can go straight to my favorite equipment. Sometimes I wait my turn. Here we are teaching the child to wait for turn, that others may also like to play, they may not like to play with me. So we are teaching this social skill for the child. So I can choose to play with friends or play alone. When the bell rings, I line up and to go inside, and recess is a great time for exercise and fun. So this has a lot of pictures, so it is easier for the child to understand. It talks about a situation and what will be happening in the situation, when it will be happening, and what is appropriate for the child to do and what is not appropriate for the child to do. Here it is about teaching the child how to wait for the turn rather than wanting to play with their favorite equipment whenever they want to. So these sort of social stories can be created to help the child understand the social situation and how to behave in the social situation. So finally, when we are coming to the role of medications. The medications, the target symptoms are generally stereotypies, hyperactivity and aggression. And low dose atypical antipsychotics are used for such behaviors, and hyperactivity can be managed with chlorine, methylphenidate and atomoxetine. But there is no medication to reverse any of these core autism features. Only these medications are given for other behaviors like stereotypies, hyperactivity and aggression. uh, so we have come to the end of our presentation. Largely, to summarize, we whenever the child is presenting with autism spectrum disorder, we go for developmental assessment, where we are trying to see what is the current repertoire of skills that the child have, what will be the next repertoire of next few skills which is in the zone of proximal development that the child will be able to do. Though it is challenging, the child will be able to learn. And we'll have to plan how we are going to teach the child the skill by creating writing a plan, and that should involve steps in which we are supposed to teach this skill to the child. Once we are able to plan and create the learning steps, then we'll have to monitor progress as to how the child is able to learn, whether the learning targets are achieved. And it should happen in the play, and it should happen in the daily routine of the child, and that should be appropriately reinforced. And what are the training techniques that we are going to use? It's applied behavioral analysis principles. Like we will start by modeling the skill. Once the child is able to do, we'll prompt the child, starting with physical prompting, followed by verbal prompting and gestural prompting. Then once the child is able to do the activity, we will help the child do it in a better manner by shaping. And sometimes if it is a larger skill, like the skill can be, we can use forward chaining and backward chaining as well to help the child learn the skill. So this all happen in naturalistic environment, in a play based activities. And once the child is able to learn the skills, then we can review and then move on to the next skill. So, how do we do that? I'll give you a few case examples before I wind up the session. This is a child who is a 6-year-old boy, who is first child born of two non-consanguineous marriage, studying in kindergarten, with typical development till 2 years, followed by regression at 2 years without any clear precipitating factor, with progressive decline in verbal and non-verbal communication and socialization over next 6 months, with complaints of slow acquisition of language and social skills, with child currently using single words and gestures to communicate needs, and stereotypic hand flapping and running around in circles, and requiring assistance for self-help skills. So what do? We apply the checklist. We have used ComDeal checklist over here, where the child is able to do up to 54 months, age of 54 months in gross motor domains. In fine motor domains, there are some inconsistency, some skill that the child is not able to do in between, but able to do largely age appropriately. Whereas with ADLs, the child is able to do till the level of 5 years, and some receptive language and expressive language skills. Though the child is able to understand and receptive language is much better, expressive language skills we can see it is at the age of 3 years only. And the cognitive skills are also inconsistent and interspersed across various age groups. And the socialization skills is also up to the age of 3 years only, and emotional skills are still behind, where the child is able to do only at the level of 2 years. So based on the items that the child was able to do, and based on the items that will be there next, we have, these are the targets that we have identified, where gross motor skills, the target will be to trying to catch a ball, throwing a ball overhead, kicking ball, running or changing direction. Whereas with fine motor skills, using crayon, you are doing art projects and precise marking with crayons. Whereas with the activities of daily living, giving empty dishes to adults, serving self at table, feeding self with little spilling, washing hands independently. Whereas with receptive language, again, we responding to sit down, understanding 3-step directions, knowing differences between top and bottom. Whereas with expressive language, asking help for personal needs, using two-word combinations, saying name of toys consistently. Whereas emotional skills, demanding parents' attention, improving language related to emotions, talking about using words like happy, sad. So we see what is the next level of skills that the child will be able to achieve. We take 2 to 3 skills in each domain, and then we plan and integrate these activities in a play based manner. For example, here, trying to catch ball. So we start by having some balls and sitting with the child. Once the child wants to play ball, then we can start by catching and throwing ball, and this will help the child to learn the gross motor skills also. At the same time, the child will be able to learn turn taking. The child will be able to play, where interact with other children and play ball cooperatively with other child. So this sort of play activity can be planned, where we can include multiple domains in a single play activity, and we monitor for progress, whether the child is able to communicate with the adult, then if another peer is included, whether the child is able to communicate with the peer, and how generalized the skill is across different situations. So we monitor the progress and then move on to the next target. So, coming to another case where we have a 5 year, 8-month-old child, single born of non consanguineous marriage with delayed birth cry and history of delay in language and social milestones, diagnosed with autism, and undergoing speech and occupational therapy since then. So, when we saw the child was able to communicate in 3 to 4 word sentences, use more than 1,000 words, understand two-step commands, use of common objects, and could use WH words. And though the child was mispronouncing some letters, the child was able to largely speak well. There was echolalia and talking to self also. The child even could narrate simple stories by prompting. And but the communication and socialization is better with parents with very poor verbal and non-verbal communication with others. The child was staying abroad, and there were no opportunities for the child to communicate with people outside the family because of the language barrier. So there was poor initiation and reciprocity noted with peers and adults outside the family. So cognitively also the child could identify colors, identify numbers and letters. So even ADLs are largely independent. Here the focus was largely on generalizing the skills. So by here we wanted the parents to create more opportunities for the child to communicate with peers and adults, so that the child is able to use these skills across different people and different situations. And initially the mother was asked to do prompts whenever the child is able to do the able to communicate or socialize with other people. Once the child is able to do these skills consistently across different domains, then we discussed about fading those prompts by starting with and decreasing the prompts from physical or gestural prompts, focus on the next level of skills. So these skills, though the child has these skills, these are inconsistently performed across different domains. So generalization was the problem. But at the same time, we'll also focus on the next level of skills that the child should be able to achieve. Whereas we found the emotional vocabulary was poor and narration and conversation skills were poor. Those are the targets that we had. When we come to case 3, this is a 5-year-old boy who is a temperamentally difficult child with history of delay in speech and social milestones and regression at 3 years of age, and history of understimulation in early years and high expressed emotions. Currently attending special school with very poor verbal and non-verbal communication, poor joint attention, poor pointing, poor imitation, with predominantly need-based communication, which is also using limited gestures by just by hand leading with the parents, and poor socialization and poor peer play, and poor sitting tolerance and poor attention and increased activity levels and temper tantrums in this child. So the child, though attending special school, the largely the child's communication and socialization was need based only with only hand leading, even the pointing was absent. So here we should focus on prerequisite skills for language development, which is joint attention and imitation. Only when we start with those skills, then we'll be able to move on to non-verbal and verbal communication as well. So here the primary hindrance was poor sitting tolerance and poor attention and increased activity levels interfering with therapy. So in such situation, we may have to go for medications to help the child focus in therapy, and for that will help in skill development in therapy sessions. Uh, that will be the end of my presentation. Thank you. Basically, we are going to use the principles where we are going to use reinforcements, and we are going to use modeling, prompting. So the principles will be the same, but the situation that we are going to use and how we are going to use it are little different than how we used to do earlier. It's not like making the child sit in the chair and we are going to sit in the chair in front of the child, showing a card and showing that this is car, this is apple, and then reinforcing the child. It is more about during play we are actually playing with cars, playing with apples, and during that natural setting we are making the child learn that this is a car, this is an apple. We generally don't start melatonin immediately, but we do give some children melatonin even before the age of 3 years also. That largely children with autism, they may have difficulty in setting routines. We initially start by having a routine for the child, where we have a specific time where the child is should go to bed, and the specific routine, unwinding routine before they go to bed, where they can brush, they can talk to each other, and have a soothing routine before they go to bed. And also we follow basic sleep hygiene rules, where the lights are switched off and it is not noisy. So we try and do all those things for children with autism. Sometimes children may find it difficult even after doing that. In such cases, we do start melatonin at early, very young ages as well. I'm not really sure of the statistics. I'm not sure of the percentage of incidence of dyslexia. But again, with children with autism, since speech and language development is a difficulty, they generally go on to develop difficulties in understanding, comprehending, reading, and writing languages. That do happen even though the child may not have per se language delay. Communication delay might be there, language delay might not be there. Understanding the pragmatics of language and understanding the meaning of written language can also be difficult for children with autism. Yes, storytelling. We generally use storytelling sessions and social stories to help the child understand the social situations, help the child understand language and communication. So, children with autism prefer to learn something visually. So, whatever we are, even with RRBs, the management, we even with the other problematic behaviors also, we generally use a visual chart to help the child understand. So use of stories and a lot of images can help the child learn faster. In children with autism, we generally use those stories. Yeah, it is very difficult and challenging for the parents, that is true. But a lot of times parents tend to focus only on the aggressive behaviors rather than understanding where the aggressive behaviors are coming from. Most of the children with autism, the aggressive behaviors are seen when the child has significant communication challenges. The child may not be able to communicate even needs properly. So when the child is not able to communicate what they need, the child is not able to communicate their emotions, then that can present as aggressive behaviors. So understanding what are the antecedents for these behaviors and whether there is a communicative intent for these problematic behaviors, we'll have to try and address that rather than just focusing on using medications or giving management for just for aggressive behaviors. We should understand where these are stemming from and then plan the management. So largely it has been used, but there is no much evidence base to say that hydrotherapy is helpful. But swimming is something that is advocated for a lot of children with ASD. It helps to calm the child, helps them to because a lot of times children do have sensory difficulties. Swimming and being in water helps them soothe themselves. So hydrotherapy as a therapeutic method, I'm not sure how much evidence that it has, whereas swimming as an activity to help the child is generally advocated. We generally start with 3 mg also, and then we go on for 5 and 6 mg. It's not any weight specific or anything like that. So again, as I have said earlier, we initially start by understanding and and developing a routine for the child. When the child is not able to do despite all those things and it is very significant, then we go for melatonin. And sometimes children may be able to fall asleep after some time, and they are able to sleep for 7 to 8 hours in the day. Then we don't prefer going for melatonin immediately. We try to create a routine for the child, going to school, going to therapy sessions, having some soothing activities before they go to bed, so that they are not excessively stimulated. Then if that nothing is working out, then we go for melatonin. And moreover, if we also try to understand, is there any hindrances for the child. The child may be having this repetitive behaviors more in the night, where they are so sensitive, sensory sensitivity is there, that is preventing them to fall asleep. So we try to understand whether there are any hindrances for the sleep routine, and we'll try to address that. If we are not able to address that and it is very significant for the child and the parents to manage, then we go for melatonin.
Okay. I would like to ask about the high functioning autism. What sometimes we call it as Asperger's, and then especially with late adolescents and then young adults, they meet with the challenges of aggression, managing them. How much psychotherapy and then counseling will be of help?
In children with high functioning autism, when they come to that adolescence, their understanding of social situations, there may be difficulties in pragmatic communication. They may be able to largely communicate, but they may not understand the social situation. They may not understand that the other peers are being sarcastic, and they may end up taking things very literally in a concrete manner. So all these, when that can result in some mood disturbances or anxiety. So in children with high functioning autism, we generally find difficulties in adjusting with peers when they are going through adolescence. And also we see children like not able to understand how to interact with other gender, and they do not know what is okay, what is not okay, how to interact with other gender, and what, like touching other gender might not be okay. They end up doing those things. So there are certain pragmatic uh, communication deficits and socialization deficits that can result in these sort of mood disturbances like anxiety or depression, and that in turn can result in aggression. Whereas yeah, and moreover we also see children with the high functioning autism, they have higher order RRBs, which are like being insistence on sameness and having a rigid routine. And that can, when that is not happening, there can be a lot of anxiety that can result in some aggressive behaviors or sensory sensitivities, and they are not able to tolerate uncertainty, and that can also result in anxiety. So largely the aggressive behaviors, if we are seeing in adolescents also, it is stemming from their lack of socialization skills, and also from higher order RRBs. So we try and understand how much of this aggressive behavior is stemming from which component. And even with with social skill training is something that we do in such children. And also with RRBs, children, we try and identify what is okay and what is not okay. Completely taking trying to change all the RRBs is not possible. So it is a way of coping for the child as well. So whatever RRBs that is causing interference to other people, we try and address that. Whereas where some RRBs that the adolescent is doing, but it is not much interfering and helping them keep themselves calm and soothing, then we try and educate the parents and even other stakeholders, like even teachers and even other peers if possible, to help them provide an environment which is easy for the child, which is helping the child. Psychotherapy as such, when there are clear psychiatric conditions, when there are clear antecedents for these sort of aggressive behaviors, then we try and go for therapeutic interventions. See, where we have had seen children where the child is having OCD in addition to ASD, that is resulting in aggression. So we try and go for psychotherapy, where we use, as I have said, we use a lot of images, because concretely talking about it might not be much helpful in even in such children. Using some pictures to help the child understand the antecedents for these behaviors and how it is affecting others and how that can be modified, we do tend to do. But it is very difficult, it's not easy, it's easier to say than to do it. So generally, 5 days a week is something we advocate, but lack of trained professionals, lack of these things. At least practically speaking, at least once a week therapy is something that is absolutely essential. When if they are able to provide 5 days a week, then that's great. Minimum, so minimum of 2 to 3 hours, 5 days a week. This is for therapy sessions, but the therapy should happen throughout the day with the parents. So a lot of times what happens, the parents are unaware of what is exactly happening in the therapy sessions, what are the targets that they are doing. It's like 1 hour with the therapist, they are done, and they are back at home, and they are not able to help the child in any manner. So it is always good to include the parent as a co-therapist, where the parent is also understanding these are the targets and this is how we are trying to achieve. And in addition, during the daily routine of the child also, the parent is able to provide these therapy inputs in a naturalistic setting rather than just doing therapy. I am not aware of programs. Yeah, I think Early Start Denver model, there are training programs for that. I am not aware of anything that's happening in India. So as early as possible, sometimes even children present when they are at 10 months, even 11 months, when the other sibling has ASD. And it is always better to over-treat rather than under-treat, where a lot of times parents believe that the child will develop over age. So rather than thinking like that, we can start speech therapy, we can start occupational therapy. We are not giving any medications, we are just trying to teach the skills for this child. So there is no harm in doing that. When you are seeing some red flag signs, and the child may not go on to turn autism spectrum to develop autism or diagnosable autism, but that doesn't mean that we should not treat the child when we see there are red flags. So one of our professors used to say, like, we use in Indian scale for assessment of autism, only 70 is the cutoff, and after 70 we treat the child as having autism and treat. Whereas if the child is only scoring 68 or 69, that doesn't mean that the child will not have difficulties. In fact, the children who are scoring 60 to 70 are the children we are supposed to treat. They will benefit the most, and they will be able to learn faster, and they may go on to go into mainstream if adequate inputs are provided very early. So the interventions should start early as 12 months, even before that in children where you find clear red flag signs and there is family history. And the improvement is much better when you start early, because our brain plasticity is the brain is more plastic when the child is young. Beyond a point, the plasticity decreases. And even one of the prognostic factors for autism children is that if the child is not able to speak verbally, not even a single word or verbalizations are not there till 6 years of age, it is very difficult to have verbal communication with the child even after that. This is one of the prognostic indicators as well. So as early as possible, as early as even 12 months. We don't give clonidine for sleep. We generally give clonidine to treat hyperactivity in children with autism. And again, the clonidine, as a side effect, the clonidine will have sedation, and it can be given to improve the hyperactivity. But predominantly, melatonin is preferred for sleep disturbances. If there are comorbid hyperactivity and sleep disturbances, then clonidine can be preferred. So we'll have to first differentiate whether the hyperactivity is secondary to ADHD or secondary to ASD. So how do we differentiate that? In children with ASD, largely we see that the child hyperactivity could be stereotypic behaviors, where the child is going round and round in circles, or spinning, or having hand clapping. These sort of increased activity will be seen. And also we see children with autism where a child may be very much interested in trains or very much interested in books. The child will be able to sit for 4 or 5 hours continuously with that book or train and be able to play with it. Otherwise, the child is not able to engage themselves, and they do not know what to do, what they can do outside of this, and during that time they seem to be hyperactive. So here, largely, if you try and decrease the stimulation around and help the child improve the joint attention and have some social activities, the hyperactivity generally comes down by itself. Whereas children with comorbid ADHD, it will be more of goal-directed activity. Though socialization and communication may not be there, we generally take the child to a playroom where we see children with ADHD, they will not be able to sustain attention in any objects. They will keep on doing that. For the first two sessions, all children will do because they are trying to explore. But if it is continuously happening over multiple sessions and they are not able to sustain attention with even a single object, and the hyperactivity is more goal directed like this, then we diagnose it as comorbid ADHD. So when we diagnose comorbid ADHD, then we can go for medicines like clonidine, methylphenidate, or atomoxetine, depending on the child's profile. Like if a child is having tics or seizures, we don't prefer methylphenidate. If the child is having comorbid anxiety, we prefer atomoxetine. And if the child is having comorbid intellectual disability, clonidine we prefer. So we, based on the child's profile, we go and start medicines if there is comorbid ADHD. If it is only ASD and the hyperactivity secondary to stereotypic activities, then we don't go for medicines. We generally prefer therapies to help the child. So we'll have to see what are the primary concerns of the parents and the child. So so if the child is coming at 13 years of age and the child is presenting with a complaint which is not 7 years of age, which is not regarding the skill that the child is supposed to develop at 7 years of age, then we'll address whatever the current pressing concerns. In adolescence, we see children largely having difficulties in understanding the personal spaces and social spaces. What should be done, what should not be done. If that is the concern that they are presenting at 13 years of age, maybe we will address that first. Then we also think of developing the skills that the child is not supposed to develop at 7 years of age and 8 years of age subsequently. Intellectual disability, again, even with children with autism, even children with intellectual disability, the child's every child is different. It's not the same, and some children will be able to catch up very fast, and they'll be able to even go into mainstream schooling and go into colleges. Whereas some children, even with good therapies, they might not be able to do. That depends on their brain abilities and capacities. So whenever we are planning targets, also when we start with 12 weeks initial targets, we'll see how fast the child is able to achieve. So even prognosis will be based on how fast the child is able to learn in the initial 12 weeks, and based on that, if the child is able to learn well, then we will move on to next targets. If the child is not able to learn, then we will also extend for next 3 months. Also the targets will be, we will maybe pick 1 to 2 targets for the 3 months rather than picking up multiple targets for that time period. So it will vary from child to child, and we have seen children who have improved drastically well. Also, we have seen children even having very limited communication, even having inability to communicate their needs. Also, we are seeing children presenting like that even in adolescence. So it will depend on the individual factors of the child and other environmental factors as well. So RRBs will be once they are able to do the RRBs, they are soothing for the child. They are generally the child will feel that after doing the RRBs, it is generally pleasurable or soothing for the child. Whereas it is for compulsive behaviors, it will be an anxiety. Without doing that, I will be anxious. And also, we can, based on the content of these repeated behavior, also we will be able to differentiate to some extent. Where we see in OCD, there are typical these obsessions which are very difficult, where you are getting repeated thoughts of something that is coming to the mind, whereas it is not associated with these sort of repeated obsessions. RRBs are not associated with that. Whereas compulsive behaviors, you will typically see some obsessions, and also there is this anxiety. Whereas with RRBs, there are no obsessions, and there is an anxiety preceding. There will be a pleasurable or soothing effect with doing the RRBs. So, sensitivity, we generally use scales like sensory profile or short sensory profile, where we see what are the, it can be the child may be seeking some sensation, the child may be having sensory sensitivity, or they may be having registration difficulties also. For example, we see children where the child may be having sound sensitivity, at the same time, the child may be seeking some sounds also. Like they might be having difficulty in hearing whistles or cooker whistle or mixer sounds, whereas they may be dropping objects and trying to listen to those sounds as well. So we try to understand across different sensory domains what are the difficulties that the child is having, whether that is a sensory seeking thing or sensory sensitivity thing. Then based on that, we generally this occupational therapists will advise for some sensory diet, where they are giving some sensory based activities that gradually helps them adapt to their sensitivity.